Thank you, Anuradha, for very pertinent question. And thank you, NSHM Knowledge Campus, Anuradha, Dr. Anuradha Mukherjee, for inviting me over here in such an empirical session where I'm kept on auscultating since morning. So this is a very important topic about the GLP-1 RA and the GLP-1. So we know since this term since a long, but the GLP, Arnav rightly mentioned that GLP was glucagon-like peptide, which is actually in secrets from our enteroendocrine cells, which is actually in our body. But the problem is that it can't stay so long because of DP4. Dipeptyl peptidase 4, DPP4. That's why you all know about some drug, DPP4 inhibitors. Dr. Amit is there, but gliptin, linagliptin, sitagliptin, all the drugs used for increased insulin. So basically they are resist insulin. So these drugs are working for increase the insulin secretion for the diabetes population. But unlike this GLP-1, we have some another synthetic composition. Lot of cutting edge DNA technology from the East and different DNA mechanism these medicines being produced, and there are very less chances of the DPP4. So that's why these medicine can stay as long. So that's why it can treat the obesity, the diabetes management, and lot of other comorbidities. Nowadays, apart from the diabetes and obesity, it's been used with the cardiovascular problem and other syndromes and non-communicable diseases. The difference between the GLP-1 and the GLP-1 RA, the GLP-1 RA is in your hand. Better the physician's hand, they will up-titrate these drugs according to the patient condition. Where GLP-1 sometimes doesn't stay in your body for the prolonged timing, but the GLP-1 RA can stay. Though those have lot of adverse, lot of side effects that we'll be discussing later on, but the classical examples of these drugs are semaglutide and the tirzepatide. But the semaglutide is the GLP-1 RA and the tirzepatide have both, but glucagon-like peptide 1 is there, and also the GIP, like glucose-dependent insulinotropic polypeptide or gastric inhibitory polypeptide. So both drugs are there in the tirzepatide. Because why? Because tirzepatide have the potentiality for the fat metabolism. For the fat metabolism and reducing the ectopic fat. So it will be working for your fat, for using for your fat. So less chances of the sarcopenia and other things in tirzepatide rather than semaglutide. So these are the classic example. And apart from theoretical dulaglutide, a lot of other things are there. But in India, semaglutide and the tirzepatide are going on, and that should be prescribed by a physician.
Thank you. So now please tell me or intro, you are practicing with the GLP-1 RS patients. So what should be the MNT, the medical nutrition therapy? So they should follow. What precautions they should take to maintain the breathing, the weight loss also?
This is a very, again, important question. About this MNT, which is very subjective, which is theoretical, but which shouldn't be. That should be a patient voice, because we have already seen, we already know that after the GLP-1 RA, there are a lot of changes. They are slower gastric emptying, and there are other things like there sometimes is involved with their nucleus tractus solitarius and also the hindbrain, and also their brain with the nauseatic activity, which is basically coming from the nausea, vomiting. This kind of sensitivity can come up. And indirectly, if you go for a patient with a gastroparesis, and sometimes with a patient will having immediately effect with after the food, patient can able to tolerate that particular day they are taking the injection. So we have to wait for a bit. Maybe we can start with the liquid diet. At Shomindu say about there any kind of formula. Any kind of formula they can start directly, but very sip-wise and very small frequent meal-wise. Not too much of solid food immediately. After patient can cope up with the injection, they can start the diet according to their calorie free. But where after having the GLP-1 RA, patient feel very anorexic. So patient sometimes not able to have too much of calorie. Maybe we are prescribing 1200 kilocalorie, 1400 kilocalorie, but patient sometimes not able to have that particular amount of calorie. So we can start with at least 1000 kilocalorie, good amount of high biological value protein. We can start and we can see and also there are sudden changes about the gut motility and also the gut microbiome and altered gut, their different symptoms. So patients sometimes having the constipation, sometimes having the diarrhea, loose motion. So the muscle contraction is much more higher. So different scenario can have. It's not only again one side doesn't fit all. So we have to see what is the complication. A clinical dietitian or a counselor of the GLP-1 RA have to talk with the patient. What about the symptoms? So accordingly we can customize the diet. If it is constipation is happening, we can increase a good amount of the dietary fiber, and that to resistant maltodextrin. It could be again is good for the GLP-1 and peptide worldwide, because resistant maltodextrin can't work in your small intestine, it can work your large intestine and the large colonic epithelium, good for the patient. If it is a patient with the diarrhea, then we can stop any kind of dietary fiber, try to at least prescribe low FODMAP diet or low residue diet, and if we want to involve with any kind of commercial feeding, we try to go for the monomeric or oligomeric formula, where protein is already in peptide based formula. But sometimes it's not only protein, we shouldn't forget about the carbohydrate, fat, and also the micronutrients. There is a term called the hidden hunger, where all the micronutrient deficiencies can happen. Copper, zinc, iron, vitamin D3, selenium, sometimes iron. I already told about the iron. So we have to incorporate those particular kind of a micronutrients, maybe with the supplements, maybe with the other channels of the vitamins and the mineral segment. And this is the way, and not to forget to take the water. The water should be the essential part for the hydration. So we try to keep hydrated for the patients, because we know after having the GLP-1 RA, these symptoms can happen. So accordingly we can treat the patient. So again, it could be a precision-based medicine practice and a precision-based dietary practice.
Absolutely. Because what kind of minerals and the vitamins we can incorporate in their diets? Can you please tell a little bit?
Yes. What I will say that vitamin D3 is a very important minerals and important vitamins. And apart from that, if we talk about the vitamin B1 and vitamin B12, like cyanocobalamin, all the vitamin B are very important. And the minerals already talked about, iron, talked about zinc, talked about selenium. This is also simultaneously important. But you shouldn't forget about the omega-3 fatty acid, because there is a crucial role of the omega-3 fatty acid and the leucine. We all know that branch-chain amino acid leucine is a very important part, because leucine sometimes activate your cystine 2 and the GATR. These kind of combinations to encourage a lot of protein synthesis and try to reduce the lean protein mass. So these are the very important things. So if we include the omega-3 fatty acid from the dietary sources and other sources from the capsules or omega-3 fatty acid oil, that could be again beneficial for the patient. So we have to talk about the overall nutrition, not particularly any particular nutrition. So we should take care about the carbohydrate, take care about the protein, take care about the fat, take care about the vitamins and minerals.